We are live, sir.
Okay. Good evening, friends, and welcome to the 7th episode of All India Postgraduate Teaching Program, which is a new initiative from ARC AIOS. This particular program of All India Postgraduate Teaching was conceived and was a dream of our President, Dr. Harbansh Lal. And he entrusted the ARC with this particular activity. We are very happy that today is the 7th episode and we are getting a very roaring response in the form of participation from various postgraduates. This postgraduate program is with a difference because it covers the uncovered aspects of teaching program like case presentation, journal clubs, OSCEs, and didactics on topics which are not comprehensively available in a textbook. Last episode on Cornea was about a journal club. So here we are with the 7th episode of the series, which is a didactic lecture on artificial cornea, which has been asked as a long question in MS or DNB finals. Today, didactic lecture would be presented by none other than the Doyen of Cornea, Professor Dr. Rajesh Sinha, who is a professor of cornea, lens and refractive surgery at RP Center, AIIMS, Delhi. My special thanks also goes to Dr. Soham Basak, who is a consultant at Cornea Department, Disha Hospital, Kolkata. Dr. Ikeda Lal, who is an additional director, Delhi Eye Center, and consultant at Sir Gangaram Hospital, New Delhi. And the third cornea surgeon is a dear friend of mine, Dr. Madhu Daraju, who is also a director of Sri Kiran Institute of Ophthalmology, Kakinada. And I'm really thankful to all these three discussants for being with us for the sake of postgraduates. We are very proud of about the episode's viewership. Our last episode had a viewership of almost 2,460 with Facebook viewing of 900, YouTube of 300 and web 260 plus. I would be now requesting Dr. Rajesh Sinha sir to share his screen. And I would also request our ARC members who are a bit learned about cornea, that Dr. Kasturi as well as Anaghar, who will be chipping in during the discussion time. So over to you, Dr. Rajesh Sinha, without much ado.
Thank you, Dr. Prashant. Thank you, team ARC, for this opportunity. And I'll be talking about a very difficult topic, I would say, as far as the clinical cornea is concerned, which is artificial cornea. And let me just, okay. As you all know, that cornea is the window of the eye, because it is through cornea you see the world. And this cornea is a transparent part of the eye which covers the front portion, and it is the first refracting surface. And it has bulk, the major bulk of the total power of the eye, and that is 2/3 of the total power of the eye. Out of 60, it has 40 plus diopters of power of the eye. So any disorder that can affect the transparency of cornea, it is a transparent structure, and that's why it allows the refraction of light. So any disorder that affects the transparency of the cornea, that can cause marked reduction in vision because of the high power it has and because of it being the first refracting surface. So disorders like healed keratitis, as you can see here, resulting in leukomatous corneal opacity, then bullous keratopathy, keratoconus causing distortion, then keratoconus with scar, then granular dystrophy, lattice avellanodystrophy, macular dystrophy, corneal scar post-traumatic, covering the central part of the cornea, obscuring the visual axis. So if you have an opacity like this, what do you want? You want to remove the opacity, and you do a penetrating keratoplasty. If the opacity is partial thickness, you can manage with lamellar keratoplasty. But if the opacity is like this, you have to do a penetrating, that is full thickness keratoplasty, so that the visual axis becomes clear. So the idea is that if the cornea is cloudy, remove this so you get a clear area and close the wound with a clear donor lenticula. This is how it works. And in conditions like keratoconus and central corneal scars, non-vascularized opacities, bullous keratopathies, etc., it has a very good anatomical success. Say, for example, a case of a bullous keratopathy, and this is how it has cleared up the visual axis. However, in corneas which are badly vascularized, as you can see here, young recipients wherein keratoplasty is a chance to fail, vascularization more than 2 quadrants, high risk graft, chance of graft rejection is very high. Large graft again carries the risk of rejection because it is close to the limbus and the blood vessels. Then some other factors like if there's presence of inflammation, loose sutures, etc. If it's a previous failed graft, then again the risk of failure of corneal graft is very high. And in cases like young patients or heavily vascularized corneas, the risk of graft rejection is very high. And if there's a graft rejection, the whole purpose of clearing the visual axis is jeopardized. And if you do regraft in these cases of graft rejection, then in that case, the risk of failure of that graft keeps on increasing as you keep on doing more and more grafts in these cases. So what to do? An option is artificial cornea, which is also called keratoprosthesis. Kerato means cornea, prosthesis means artificial. So it's a procedure where a diseased or scarred cornea is replaced by an artificial cornea. That artificial cornea can have different designs. Many designs have been described, but it is a procedure to clear the visual axis when the cornea becomes scarred or diseased. Now, keratoprosthesis, when we are discussing, then we have to discuss about temporary keratoprosthesis, permanent keratoprosthesis, and there's another group which includes biosynthetic material, which is used for specific types of keratoplasties. So when we talk about temporary keratoprosthesis, then it means it's a device which is used temporarily to clear the visual axis. So why do we use it temporarily? If we have to do some surgeries behind, if we have to evaluate the retina or structures behind the cornea. But because the cornea is scarred, we are not able to do so. So in that case, if we cut the central scar area, put a temporary keratoprosthesis, we can evaluate the retina, we can evaluate structures behind the cornea, opacified cornea very nicely. And we can do surgeries as well. So mostly a temporary keratoprosthesis is used when we have to do a vitreoretinal surgery in order to have a clear view of the retina and the vitreous and the structures behind the cornea. Now, various types of temporary keratoprosthesis have been described. The first ones are the original Landers one, which were used earlier, no more used. Then this wide field Landers PMMA keratoprosthesis is the one which is commonly used. And then we also have Icart silicone keratoprosthesis. So there are wide varieties. There are many more, but these are the ones that are commonly known and commonly used. You can't remember each and everything, but you should remember a few things which are really important in your clinical practice and in your day-to-day life. So the Icart one, as I showed earlier, it is made of silicone rubber. The Icart silicone keratoprosthesis, it is made of silicone rubber. And it is secured in position by nylon sutures. But what happens that silicone, since it is soft, when it is passed, the sutures are repeatedly passed, it damages. It causes multiple suture tracts. And sometimes when you're doing a retinal surgery and you're using a silicone rubber, then it can cause clouded view during air fluid exchange. So the one that is most often used as far as temporary keratoprosthesis is concerned is Landers keratoprosthesis, which is wide field Landers keratoprosthesis, the newer variation of Landers one, which has a hard polymethyl methylcrylate with a central core of PEG, and it is available in diameters of 6.2, 7.2, and 8.2 millimeter, but refined size of 6, 7, and 8 respectively. Now, most of the times you use either 7.2 or 8.2. depending upon the size of the cornea, depending upon the size of the pathology. So most of the times, as I said, we use either 7.2, 8.2, because when you create an 8 millimeter incision, you have to snugly fit it. And that is why it is 8.2. So just an example, a case of a bullous keratopathy, decompensated cornea. When the patient came to us, when the ultrasound was done, it was found that there's a lens that has fallen behind. So we had to do a vitreoretinal surgery in this particular case. And how to do vitreoretinal surgery to remove the lens? The only option is a temporary keratoprosthesis. So you measure the corneal size, and then accordingly you plan for the wide field Landers keratoprosthesis. So you create a mark because you have to do a penetrating keratoplasty subsequently after doing the vitreoretinal surgery. So you have to be absolutely sure that the groove and the mark is in center, so that subsequently you can have a central graft. So this is how you remove the tissue. You first refine, and then when you're cutting the cornea, you keep the blade vertical so that you don't have a ledge. And then once this is done, temporary keratoprosthesis is being placed. Now there are holes here, which is through which sutures can be passed. You can use any suture. You can use nylon suture. You can use toluene suture to fix it up. And once it is fixed, there's no leak through it. You can go ahead, do a vitrectomy. And then as you can see, the vitrectomy is being done. The IOL is lying flat on the retina. So the IOL is being picked up, and then it will be lifted up. Once it is lifted up, you bring it with the forceps up. You can also use PFCL in these cases to lift it up, or you can hold it with the forceps. And then you ask your assistant to cut these two sutures and then use another forceps to take it out. So you can see here, this is a broken IOL that was that had fallen behind. And now you remove all the sutures, remove the temporary K-Pro, and then you place this donor lenticule, and then pass multiple sutures, first 4 sutures, then the remaining 8 sutures, and the next 8 more, 16 sutures will be placed, and that is the end of the procedure. So this is the use of a temporary keratoprosthesis, and it is quite an important thing. Now, coming to the permanent keratoprosthesis, which is used as a replacement for penetrating keratoplasty. So we do normally penetrating keratoplasty in all corneal scars, but keratoprosthesis is an alternative approach. Why? As I said earlier, if the cornea is heavily vascularized, if there are multiple times failures, if it's a dry surface wherein you can do a specific type of keratoprosthesis and where penetrating keratoplasty will not survive. So all these things can be handled by keratoprosthesis. There are various designs that have been that have come up. As we are talking about keratoprosthesis, we should know a little bit about the history, because people who have worked on it, we should definitely know about them. So it was in 1789 that Pellier de Quincey, he gave the concept of keratoprosthesis. He used a glass lens in silver ring for a leukomatous cornea. Then in 1853, this is one which he described actually. In 1853, Nussbaum again described a collar stud glass device consisting of 2 plates sandwiching the cornea. And then in 1859, Husser was the first to implant a keratoprosthesis in a human eye. In 1950, Stone and Herbert gave the PMMA prosthesis. Then in 1963, Stampoli gave the idea of osteodontokeratoprosthesis, which was further modified by Farcinelli. And then Pintucci keratoprosthesis and alpha core, all these things came into practice. So the indications are, as I said, bilateral blindness. It is never done in unilateral blindness. bilateral blindness with normal posterior segment on B scan. Then if it's a very severe, debilitating and inactive anterior segment disease such as Steven-Johnson, chemical burns, trachoma, etc., multiple previous failed grafts wherein the chance of graft failure is again very high. If it's a badly vascularized cornea with complete stem cell loss and dryness, so all these can be considered as indications. And there are many keratoprocesses that have been described, as I said earlier, the Pintucci and other ones also. But the ones that are most commonly, that have been most commonly used are the osteoodonto keratoprocesses and the Boston keratoprocesses, type 1 and type 2. Lucia is a slight modification of Boston keratoprocesses as well as the oro keratoprocesses, which is an Indian counterpart, again a modification of a Boston keratoprocesses. So coming first to osteoodonto keratoprocesses, it was first described by Strampoli in 1963. It was modified by Falcinelli and others. And then what happens in this is, as the name suggests, osteodonto. So we use patient's own tooth root and surrounding alveolar bone to support a centrally cemented optical cylinder. And it is a multi-stage procedure. So in this, we use a wide single rooted tooth. And most often it is the canine tooth which is used because that is a wide single rooted tooth. Others are multi-rooted tooths, or the root is not wide, but canine has the widest root. And it is needed because you want to create a drill, 3 mm hole in that. Okay. So as I said, this is the canine tooth which is taken. You drill a central 3 mm hole, put a cylinder in it, and then you go ahead. So as far as the steps are concerned, when you are planning to do a OKP, the first thing that you do is that you do a corneal trephination, a very scarred, badly scarred cornea, irregular cornea. Sometimes you may not have to do that, but in most of the cases, you may have to do this corneal trephination. Then you remove the iris, you remove the lens, you do some vitrectomy. Then you also put Ahmed glaucoma valve in most of the cases, because in post-op period, it will be difficult to handle glaucoma, which may be seen in these cases. And then after that, you put a donor cornea, suture it, and then since it's a dry cornea, you have to put some conjunctival layer over it, and then you take a mucosal graft to make it wet. So you take buccal mucosa close to about 2.5 to 3 centimeters, and you cover it up, you anchor it with recti sutures, and then you cover it up, and then take a canine tooth, extract it, and then fashion it to create a lamina, drill a hole in it, 3 mm diameter, put the PMS cylinder and insert it in a subcutaneous area in the opposite cheek. So create a subcutaneous pocket and put it in the opposite cheek. Why? Because you want to create blood vessels into that lamina. And then once you have done that, so see, this kind of a keratinized corneas can be handled with it. So you have put the mucosal membrane, the canine tooth and the cylinder is there in the cheek. Then a couple of months later, you remove that, and then you reflect this mucosal membrane, and then create a central 3 mm hole into the cornea, fit it into it, and then close the mucosa and create a central opening so that the cylinder jets out from it, comes out of it. Well, there can be some risk of rise in IOP as far as complications of OKP is concerned. It's a very long and very cumbersome procedure, and that's why very few people do it. Then there can be exposure of the lamina, there can be infection, there can be detachment, there can be end off, all sorts of things. The one that is very commonly used, obviously it cannot be used in dry eyes, but if the cornea is wet, if the surface is wet, then the one that is very commonly used is the Boston keratoprocesses type 1. It was approved by FDA in 1992, and it is used in eyes with a good tear film. It has an optical cylinder which is made of PMMA. This is the one. This is the corneal graft wherein you make a central opening. Then you fit it in. Then this is the back plate, which is again fitted into it. And this is the locking ring. I'll just show everything. So in a Boston keratoprosthesis type 1, a donor corneal tissue is punched 8.5 or 9 millimeter by a circular cutting trephine. Then the center of the tissue is marked. Then you punch centrally, create a 3 millimeter central opening. And then the corneal lenticule is fitted into the central optical cylinder. In its central opening, the back plate is fitted, the locking titanium ring is fitted, and it is sutured like a keratoplasty. So this is the corneoscleral button. You first create an 8.5 millimeter opening, then you create a central opening of 3 millimeters. As you can see here, the central opening is there. Then you fit it, the PMA cylinder is put into over a sticking gel pad, and then you put the corneal tissue, the back plate, and the titanium ring. I'll just show you a small video clip. See, this is the 8.5 millimeter tissue wherein the central trephination has been done. So this is the cornea with a central hole of 3 millimeter, and this is the PMA ring, PMA cylinder. So it has been put through the hole, and then this is the back plate. And then once you have put the back plate, this is the titanium locking ring. So this is how you do it. And once it is there, you remove the corneal button with a trephine, do a little bit of a vitrectomy, and then this artificial cornea, which is not completely artificial, but partly artificial. Part of the tissue is, of course, human tissue, wherein with helps in securing it in position. So this we put 16 sutures just like keratoplasty and secure in position. This is how it looks like. Another case of a badly vascularized cornea and a Boston K Pro type 1 has been done, and it gives rise to very good visual acuity. Type 2 is through the lids. In severe dry eye, Boston keratoprosthesis type 2 can be used, and it has a longer surgical procedure. It has a nub, 2 millimeter nub, which protrudes through the lid. So this is the basic differentiating feature between the Boston keratoprosthesis type 1 and type 2. So it has a front plate of 6 to 7 millimeters. In type 2, again, it has a front plate of 6 millimeters. Back plate with all these holes, 7 to 8.5 millimeter with 16 holes, 8.5 millimeter again with 8 holes. Then you have a stem, both have stem. In type 2, since it has to go through the lid, this is the 2 millimeter long anterior nub of front plate. And that is how it comes out through the lid. So, as I said, it provides very good visual acuity. But the thing is that the biggest problem that can happen is melting of stroma surrounding it. That is something which can result in extrusion of device and all sorts of things. Apart from that, there's risk of infection, and then, of course, retroprosthetic membrane. There can be uveitis, there can be retroprosthetic membrane, there can be vitreous membrane as well, ERM, endophthalmitis, retinal detachment, glaucoma, all sorts of complications can happen. However, these are desperate situations wherein if the patient has a good vision for a reasonable time, that is quite good, and we may have to, if it extrudes, then we may have to repeat it. And you can directly repeat, or you can just do a therapeutic graft. If it has melted, you can do a therapeutic graft and then do a Boston keratoprosthesis type 1 later. If it's an end stage or uncontrolled glaucoma, one should avoid putting it because it in itself has the propensity to cause glaucoma. So there's risk of optic atrophy completely. Or if it's a borderline kind of a thing, you can use Amath glaucoma valve and then go ahead and perform the procedure. If there is posterior segment pathology, then of course you should not do, because there will not be any benefit. And if it's a unilateral blindness, there's no need to do that. Now, coming to some synthetic inlays. Alpha core was the one which was described as an artificial cornea in a real sense, because it was an inlay into the cornea. And it was first implanted in human eyes in 1998. And it was approved by FDA in 2003. It is made up of polyhydroxyethyl methacrylate, that is polyHEMA. And this is how it looks like. The central part the overall diameter is 7 millimeters. The central optic is 4 to 4.5 millimeters. And the peripheral skirt is 3 millimeters. And the central part is clear. The peripheral skirt is porous, it is opaque, and this has it is porous, a micro hose kind of thing, wherein, it helps in biointegration. So how it works? It is made of, as I said, it is made of polyHEMA that has a peripheral region with interconnecting pores, allowing biointegration with surrounding corneal tissue. There are two concentric regions. These are joined by means of interpenetration of polymers across a junctional zone known as interpenetrating polymer network. Entire device is a diameter of 7 millimeters. And as I told you earlier, and the device is available in two powers, alpha core A for aphakic and alpha core P for pseudophakic. Now, this is how it looks like. This is the central 4 millimeters opening. Now, how it looks like, how it is done. It is placed within a lamellar corneal pocket. You create a pocket and then it is placed into it. You create a stromal pocket and it is placed into the pocket. And then what you do, you remove the posterior 4 millimeter of the posterior lamella. Central 4 millimeter of the posterior lamella you remove, and then you place it. And at a second stage, you remove the anterior lamella as well, the central 4 millimeters. So the porous skirt that is there, which is not transparent, which is opaque, it helps in biointegration. And the central part helps in visual rehabilitation. Because the cornea is scarred, so you have to cut the central part. So it is done at two stages. In stage one, the posterior part is removed after placement of the alpha core in the pocket, and then after a couple of months, the anterior part is cut, and the porous skirt remains enclosed within the corneal stromal tissue, with which it biointegrates because of a cellular colonization and collagen deposition. The advantages, because these are implanted within the corneal plane, so even post-op intraocular pressure measurement is possible. Then the procedure is reversible. No requirement of iridectomy, vitrectomy, removal of lens, glaucoma surgery, etc. So that way it became very popular, and the initial results were quite encouraging, very encouraging in initial few studies. But then gradually, stromal melts were reported and graft extrusion, then optic deposits were also very often seen. And then gradually it was felt that it is not serving its purpose. So very few people are doing it now, hardly it is done. And a modification is being done on this alpha core in order to get a better outcome of these inlays. So a new biosynthetic material now has come up. And this also is kind of an inlay. This is also introduced through a pocket. So this is a corneal implant manufactured from purified medical grade type 1 porcine collagen. There are no cells or viable biological material in it. It's an absolutely acellular. It is a class 3 medical device designed to mimic properties of natural cornea. And the collagen is double cross-linked, both chemically and photochemically, imparting strength and resistance to degradation. So it is a bioengineered porcine construct. So, and it is used intrastomally. So why it is supposed to be more, bio-friendly? Because it is again a collagen, uh, and the porcine tissue has been taken, made acellular, and then it has further modification has been done, which is of course patented and by the company that is doing it, and it is introduced through in an intrastomal pocket created by femtosecond laser. So as you can create a very nice pocket with the femtosecond laser, it can be introduced in the intrastomal pocket, and currently it is being used for keratoconus to modify the corneal topography. So it works well in cases of keratoconus, and the initial results have shown some good outcome. So a small video clip. Professor Namrata Sharma at RP Center is doing this project, and so it is a multicentric project in 2 countries. These patients have been recruited in India and Iran, and this is how you create a pocket. And so here the project in charge is Dr. Namrata, and this is the biosynthetic material that is introduced into the stromal pocket. Once it goes into, it is positioned in place, and it goes well, and then you place the bandage contact lens, and that is it. You can see here how it looks like. The case of keratoconus, wherein it has been put so the tectonic strength of the cornea increases, it becomes thicker, as you can see here in the OCT also. This is the implant that is there present intrastomally. And the initial results have shown evidence of a good result of this cell-free bioengineered collagen-based material. And the initial study has reported it to be a safe and feasible means to reverse the pathologic corneal thinning and deformation in advanced keratoconus. So in advanced keratoconus, we have been using, like I've done 2 such projects using the human cornea. And this is one project that is being done with synthetic cornea. And the results are encouraging, but only with time we will be in a position to know whether it is as effective as any other procedure, whether it takes up well. Initially, it has taken up well, and there is hardly any report of melts. But most of the times of our own experience of Kpros, the melt many times starts later. So we are keeping our fingers crossed and following up these patients. So in conclusion, there are various types of artificial corneal implants that have been attempted with various variable success. Started long back, this journey. The Boston type 1 keratoprosthesis is the most user-friendly and the most commonly used keratoprosthesis. OKP is a long procedure, effective in all sorts of pathologies like dry cornea as well, wherein Boston type 1 may not be useful, although Boston type 2 can be useful in dry corneas as well. And the newer and Indian versions have come up. As I said, that Oro K-Pro is again it's a sort of a modification of a Boston type 1 K-Pro only, and it has provided reasonably good results, but there are reports of melts as well. So earlier generation of Oro K-Pro had more melts. I believe the newer ones are better. And as I said, the bioengineered corneas now have shown good initial response, but it is a little too early to call it a total artificial cornea because it is just being used as an inlay. And then subsequently, the plan should be to use it as an anterior lamellar graft in, say, in DALCs or in anterior lamellar keratoplasties. And then subsequently, the idea will be to grow endothelium onto it. So the journey will be very, very long in order to get all these things, and whether we'll, the scientists will succeed in all these or not, it's difficult to say. But yes, the efforts are on, and this is nearly all about, you should know about keratoprosthesis. And any question, anything you would like to ask, I'll be happy to share with you.
Thank you, Professor Rajesh Sinha. We are optimistic we could land on the moon. So why not about the corneas? In the coming time, we are going to have bigger frontiers conquered by our own Indian people, I'm sure. Over to you, other people, now for discussion over it. Dr. Kasturi, madam, you can moderate the discussion meanwhile. Because
thank you for the presentation. In fact, it's really an eye-opener for all of us, really learned it. So, Dr. Sinha, you have mentioned about the OKP, the Boston, the AlphaCore, the bioengineered. So, which one do you feel is best for all the indication, whether it's for dry eye, wet eye, like with tears, without tears? Which one should we go for? And why?
Well, if you say one for all, it's very difficult to say, because it's, I mean, each has its own value, merits and demerits. But yes, OKP is something that can be used in dry corneas, as well as you can use it in wet cornea also. Only thing is that it's a very lengthy and long procedure, two-step procedure, requires multidisciplinary approach. If you have put the case in your OT, then I mean, that will be the only case that you will do the whole day, because 5-6 hours, then GA time, and all those multidisciplinary people getting involved. So that is a little cumbersome. So that's why in wet corneas, people don't like to do that. And they prefer Boston keratoprosthesis type 1 in these cases.
Thank you so much. Like, you have just read my mind. That is the only surgery where the oculoplasty surgeon and the corneal surgeon works hand in hand. So, thanks for the beautiful answer. So, Dr. Soham, would you like to add something? Like, we have spoken about everything. Do you have any experience with the permanent keratoprosthesis?
So I have primarily done the type 1 Boston keratoprosthesis and the Indian counterpart, the orokeratoprosthesis. Now, to add to the discussion, probably some names that the postgraduates should know, since Sir was talking about the AlphaCore and how it didn't work out. So now you have these newer things which have this sort of the biointegratable skirt around them. So few names for the PGs would be the Cornea K-Pro and the Gore synthetic K-Pro. So these have, again, similar central clear optic with something which biointegrates. You do not have a corneal carrier like in keratoprosthesis. So this negates the need for any human donor cornea. And the other very new thing is EndoArt. It's basically like a sheet, small contact lens like sheet, 6 millimeter, entirely synthetic, which sticks to the endothelium. So in cases of endothelial decompensation where you do not have tissue, this sort of gives some amount of, reduces the edema and gives some amount of clarity. These are like very new things which are happening in the frontier of artificial corneas.
And the biosynthetic one, which Dr. Rajesh has shown it, like that is something I think is very intriguing. Like, what is the thickness of this biosynthetic porcine one, the one you have shown, and where I think RPC has got lots of experience. I have heard Dr. Namrata also speaking about, like, how many cases you all have done and how long are the follow-up, and how do you think that it will be the ultimate artificial cornea for the people of India? Like, how many, what do you think? So
actually, I would just like to, emphasize here is that it is being used to modify the topography in cases of keratoconus. So it still has to go a long way to be labeled as an artificial cornea. But yes, it's a lamellae that is being used to modify the corneal contour. That is one. And as I said that, the next step should be that we should be in a position to do an arterial lamellar keratoplasty with such synthetic corneas. Then the third step will be to think about the endothelium. So it's still a long way, but yes, at this point of time, it is being used to, like we have been using now. I have myself done a couple of projects with my students' thesis with human corneas, and I've used a hyperopic lenticule actually. But with this synthetic corneas, you cannot do that hyperopic one. But I mean, designs can come up, and all these modifications will come up with time. But it works well. It works well, although the duration of follow-up maximum will be, I think, close to 1 year. And it's more than 1 year. Actually, in Iran, it was started a bit earlier, and maybe, yeah. So it's more than a year. And the results are showing, are reasonably good. I mean, good in the sense that it is not getting extruded. One or two may get extruded because of many reasons. But if you have done it, say 20 eyes, and if 1 or 2 gets extruded, that's nothing. So if it stays there, that also serves the purpose, because subsequently it can be, further modified in a different way, maybe for anterior lamellar grafts, and I mean, that will give us idea that how things can further be modified. That is important.
Dr. Madhu, I have a question to you. I'm sure you are helping the retina surgeons with this temporary keratoprosthesis. Like, can you tell us more for the PGs, what is the material and how do you go ahead for the temporary keratoprosthesis when you assist in the retina surgery?
Yeah. It's not only for retina surgery, ma'am. Sometimes when you have bad endophthalmitis, where the cornea is also involved and the visibility is poor. So in these cases, to finish off the retinal procedure, I think we use this temporary K-Pro that has this, as sir has rightly mentioned, the 8.2 millimeters and 7.2 millimeters. Depending upon the area of this thing, we do it. And this will aid only during the surgery. But what we have seen practically is because of these 4 sutures, the globe integrity is not very great. Now the newer models with 8 sutures have better opposition. That is one thing. And it is made up with our regular material, PMMA. PMMA is what it's made up of. And just to add to sir's this keratoconus thing where he was inserting the biosynthetic thing, ma'am. In these cases, we have been doing the Bowman's layer with stroma. Almost 70 to 100 microns of stroma we have been implanting. And in these cases, we have been able to get that biomechanical strength, make the cornea again eligible for cross-linking and all. So I think in that cases, we almost have 5 years experience now that is doing well. And coming to K-Pro, ma'am, I think we did quite a few number of RO K-Pros. I have experience only with the Indian thing, around 30 plus we implanted. As sir has rightly mentioned, though we may regain vision, over the period of years, you lose the eye to glaucoma if you don't properly see it. So of the 30 cases we did, at least 20 of them that sustained or survived required a GDD at some point of time in the follow-up. And if I'm not wrong, I mean, Soham will also agree, Dolman sir, I think puts the patient for years together on acetazolamide.
Yeah, he recommends oral Diamox for life.
Oral Diamox for life, that's what he recommends. So I think that is one important thing for postgraduates, that glaucoma is a very known thing that comes along with K-Pro, which Raja sir has rightly highlighted. So that is one important thing I wanted to highlight, ma'am. And as you had told, we should be screening for glaucoma even pre-op. So for that, the clinical thing is do a B scan. And if you are able to see a notch that is more than 0.5 cupping is there, you can appreciate the cupping in B scan itself. So these are the cases that you should be very careful while you're selecting for type 1 K-Pro, which is very important.
Actually, just I would like to add here that, as you have rightly mentioned, Madhu, if the cupping appears to be high, then in such cases, it should be associated with an Ahmed glaucoma valve.
Exactly.
So in all these cases, we should do Ahmed glaucoma valve along with the Boston K-Pro.
So
Yes.
a few things I would like to add. So here now, since we are talking about glaucoma and retinal complications that we have after K-Pro, so we can do endoscopic evaluation of the retina as well before taking up these cases, which has come up really well in the recent years. So if we have doubts whether the patient has a healthy retina or to look at the optic disc, that comes in very handy because, as Sir has rightly mentioned, doing a K-Pro is not a very difficult surgery. If we are doing penetrating keratoplasty, we can easily do a type 1 K-Pro, but the complications are the one which we have to deal with later. So we can have, along with glaucoma, we can have endophthalmitis, we can have leaks, we can have melts. So all of these complications that can occur. And one more thing I would like to add is that when it comes to the the MOKP or the K-Pros which are used for dry eye disease, LVP, when I was during my time in LVP had also come up with a modification of LVP K-Pro, which is a type 2 oro K-Pro, which is put under again a mucous membrane graft, and it's a tedious surgery, and it is done also in 2 stages, and then we cut the mucous membrane on top of it to expose the cylinder in the next stage. And again, a few cases do tend to have leaks around the cylinder and land up in complications like endophthalmitis. And the last thing, we have very exciting times ahead. I think there are a lot of people who are also working on liquid cornea, and the drops that can be instilled in the eye, which is, to simplify it, what we need for cornea is actually collagen, peptides, and proteins. To simplify the concept of an artificial cornea for postgraduates, we need collagen. So that's where the porcine skin comes in handy, because it has type 1 collagen. And then we need to add strength to it. So we cross-link it to make it more viable to be implanted inside the eye. So these are the components that we need. And the latest thing is to put, exosomes as an eye drops, which can actually remodulate the cornea, and it can cause regeneration and reverse scars. So we are long way away from making that a reality, but there's a lot of work that has been going on with it, which can get activated with the light and sets in 10 minutes, and then can modify the cornea. So we have, I think, long way to go, but exciting times ahead for cornea surgeons.
One question, Dr. Ikeda. Can you tell me what is the power of that optical cylinder? Like, that is a question I always have in my mind. Or how do you adjust the power in such situation?
Ma'am, it comes in 2 modes. I think the Boston one and the Oro K-Pro comes in 2 modes, the pseudophakic and the aphakic one. So the power comes depending on whether we are planning the patient to be pseudophakic or we are planning to leave the patient aphakic. So most of the times we need to remove the lens, do a thorough vitrectomy, and all of those things. So power would vary according to that criteria.
How to calculate the power?
Axial length.
Axial length.
There is a table. So according to the axial length, the optical cylinder power is calculated.
Very interesting.
They usually take 1 week or 10 days to manufacture it.
Dr. Rajesh, for the benefit of the postgraduate, can you just highlight what are the post-operative regime and how long do we need to follow up all these patients following the surgery?
Well, in post-op, we have to give we prefer giving fluoroquinolones like moxifloxacin, and along with that, 2 antibiotics are normally given in these, like vancomycin has also been recommended along with this. And of course, you give topical steroid in these cases. So this has to be given in a very long-term basis. And in between, if there's any doubt of infection or anything, one can also consider, some people do consider using antifungals as well. And regularly cleaning and maintaining hygiene is very important in these cases. And use of, say, diluted betadine can be used, and that is important. And plus, of course, you put a soft contact lens, large diameter, in all these cases. So it has to be replaced every 3 weeks, so that the hygiene and there's nothing trapped underneath. And the earliest sign, one should know what is the earliest sign of a melt or a leak. That is presence of a small air bubble. Suddenly, if you see that at the edge of the optic, if there's a small air bubble, this means that the melt has started. And there you have to be really careful. So this is the, no, you are mute, Dr. Kasturi.
So
So
there's no ointments to be given, only drops.
yeah. There's there's a bandage
Bandage contact
over.
lens.
Large
It's
bandage.
better not to give any ointment because I mean it will, it will take away. It will
Yeah.
take away
I
the
think,
bandage contact lens. So
Monthly follow-ups, madam. Most important is monthly follow-ups. Look for those micro leaks. Cul-de-sac cleaning with the betadine, as sir has told. And we change the antibiotics also every 3-4 months. 3-4 months you put Ciplox, then you change it to Moxie, then you can give chloramphenicol so that the resistance will not develop. And especially if we are giving to patients that are working in an agriculture background, we also give pulsed antifungals. Just we give it for 2-3 weeks, maybe every 3-4 months, so that you prevent the fungal infections also.
a follow-up is very essential. Actually,
Very essential.
first month it should be a weekly follow-up.
Weekly, yes, sir.
Then after that, in the first year it should be say 2 monthly follow-up, and then after that, after 1 year, it should be every 3 to 6
Quarterly.
months.
Yeah.
Quarterly follow-up should be done because
And steroids also, we can shift to soft steroids after 3 months, madam.
Yeah.
Because here rejection is not an issue.
Yeah.
So soft steroids like loteprednol or fluorometholone, we can start after 3 months.
So this is something very interesting. I should really thank Dr. Prashant for bringing this very interesting topic, where along with the cornea surgeon, the glaucoma surgeon, retina surgeon, oculoplasty surgeon, all of us who are working together. So we have
I think Prashant sir deserves a big applause for choosing this topic.
Yeah, he
And-
chooses the best of best topics. Like
And Rajesh Sinha sir for covering it so well, end to end, right from the history to the recent advances. I think it's very, very useful for all the postgraduate. I should congratulate Rajesh Sinha sir also for the excellent talk.
It's a really lovely presentation. Even I have learned so much. I'm
Yes.
finding it so interesting. So
I want to keep it crisp, actually,
everyone has,
because in keratoconus processes there's so many things that there's so many names, so many things. So just wanted to keep certain things
Relevant
that
and-
remember, and
Yes.
that is normally used.
Correct.
That is something that I always wanted to focus on.
No, sir, I think you have structured it very well. It will be very useful for the postgraduate.
Basically, it is a long question which was asked sometimes back in MS or DNB exam. So we wanted, and it's not available to the postgraduates in a textbook in a format. So I wanted this to be a complete comprehensive where they can really write a question and they know the basics of it, everything. So very well done, Dr. Rajesh Sinha, and in fact, all the discussions I've added further glamour to it. Great. So any more questions, ma'am? Any more discussion?
I think, we can come.
Yeah, we can conclude. So I think it's time for us to take leave. Thank you, Professor Rajesh Sinha sir, for once more accepting our invite to be a part of our ARC PG teaching program. And all the young people, all young cornea surgeons, Dr. Madhu, Dr. Soham, Dr. Ikeda, your contribution to this PG activity, which is important for building good postgraduates and good future for ophthalmology, and your contribution will be always remembered. Thank you once more for contributing to this effort of ours of ARC. And it's time for us to take leave. I think if we have some more questions, we can be forwarding you necessarily later on. So thank you once more, Professor Rajesh Sinha, Madhu, Soham, and Ikeda for all this. And of course, my own ARC team, Dr. Kasturi ma'am, who can always make the discussion more lively, being a refractive as well as a oculoplasty lady.
And a big
Thank you,
thanks
sir.
to
Thank you
the
so much, sir.
leader, Dr.
Much
Prashant
all of
Rangula.
you. And we hope to have all of you in the future meetings. But this is really a very good learning for not only the PGs, but also for the practicing ophthalmologists, targeting more to the general ophthalmologists. And this is something very interesting, which we really enjoyed, both the discussion and the presentation. Thank you, each one of you, and we hope to catch up again very soon.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.